Thank you for joining us for this on-demand MDA engaged community webinar on the Diagnostic Odyssey of Pompe disease. My name is Michelle Barrios, and I am the Community Education Specialist at MDA. This webinar is part of our larger MDA Engaged flagship community event series, which focuses on bringing the neuromuscular disease community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual events. Before we begin, I would like to thank our sponsors, Amicus Therapeutics and Sanofi Genzyme. We would not be able to provide events like this if not for their generous support, so thank you very much. Let's review the objectives for this webinar. Viewers will understand what a diagnostic odyssey is, review Pompe disease, learn how to test for Pompe disease, come to know what medical professionals a person with a potential Pompe diagnosis should connect with, and discover resources for support through the journey of diagnosis. Now, I would like to introduce our speaker. Jennifer Cohen is an assistant professor of pediatrics in the Division of Medical Genetics at Duke University. She attended Yale College and then received her MD from the Icahn School of Medicine at Mount Sinai in NYC. She completed a combined residency program at the Children's Hospital of Philadelphia in pediatrics and medical genetics before joining the facility at Duke in 2019. Her research interests and expertise are in perinatal genetic medicine with a current focus on earlier diagnosis and management of rare genetic diseases. She is actively involved in the Pompe disease gene therapy trials at Duke. Her longtime research interests and training have led her to pursue the study of in utero treatment for lysosomal storage diseases and to pursue implementation of more rapid and comprehensive neonatal diagnostic testing in critically ill infants. And with that, I would like to turn over the webinar to Dr. Cohen.
Thank you so much for that introduction, and thank you for tuning in today to hear about the Diagnostic Odyssey of Pompe disease. As mentioned, the agenda for today will include a brief overview of Pompe disease, how we test for Pompe disease, in other words, how to confirm a diagnosis, the differences between infantile onset Pompe disease diagnostic journey and the late onset Pompe disease diagnostic journey, what medical professional should a person with a potential Pompe diagnosis see, and some resources for support through the journey of diagnosis. To begin about our brief overview, Pompe disease has multiple names, and that is due to its underlying cause. It is known as a lysosomal storage disorder, as well as glycogen storage disease type 2. It has additional synonyms of acid alpha-glucosidase deficiency, acid maltase deficiency, GAA deficiency, and glycogenosis type 2. The cause of Pompe disease is biallelic disease-causing pathogenic variants in the gene GAA. This gene encodes the enzyme acid alpha-glucosidase. GAA is a lysosomal enzyme, and therefore glycogen storage may be observed in the lysosomes of muscle cells in this condition. The Pompe disease pathophysiology includes a deficiency in this lysosomal enzyme, acid alpha-glucosidase, or GAA activity, and this enzyme normally catalyzes the breakdown of glycogen into glucose in the lysosome. Without sufficient GAA activity, glycogen will accumulate in the lysosome, causing distension of this organelle within a person's cells, specifically within a person's liver and muscle cells. Pompe disease can be classified into two main types, and it is classified essentially based on the patient's age of onset of symptoms, the specific organs that are involved, the severity of that organ involvement, and the rate of progression of disease. The first category is known as infantile onset Pompe disease, and this is classified by an onset at less than 12 months old and would include cardiomyopathy as one of the symptoms. Within infantile onset Pompe disease, or IOPD, there are two classifications within that category, classic and non-classic. The classic is the most severe end of the spectrum of disease, whereas the non-classic still has cardiomyopathy within the first year, but is less severe, and typically these patients will survive past the first year of life. On the other hand, late onset Pompe disease would include all individuals who have onset of disease still at less than 12 months old, but without cardiomyopathy. That is the key distinction here. It also includes all individuals with onset greater than 12 months old. The overall incidence of Pompe disease, which means including infantile and late onset Pompe, would be 1 in 20,000 to 1 in 10,000. And this incidence has been updated following newborn screen initiation within the United States. The incidence of infantile onset Pompe disease is rarer, and that is 1 in 100,000 to 1 in 138,000. Next, we'll discuss testing for Pompe disease, or making the diagnosis. The diagnosis in Pompe disease is established in a proband, or a patient, with either deficiency of acid alpha-glucosidase, or GAA enzyme activity, and that's the biochemical testing, and or biallelic pathogenic variants in GAA gene on molecular genetic testing. Now I'll define what some of these terms mean. Biallelic means we have two variants in trans. In trans basically means that you have a variant on one maternal chromosome allele and one variant on the paternal chromosome allele. This is also known as autosomal recessive inheritance pattern. And if we move over to this image here on the right, we can see any autosomal recessive inheritance pattern, but specifically Pompe disease, where you have two parents who are each silent carriers, and they have a risk of having an affected child 25% of the time. They have a chance of having two unaffected carriers 50% of the time, or an unaffected non-carrier 25% of the time. The risk is the same for every pregnancy. And the green here represents the variant or abnormal allele, or the affected allele, and the white side indicates the normal allele. So you can see here in an affected individual, they've inherited both abnormal alleles, one from mother and one from father, versus the unaffected carriers, who are similar to the mother and father in that they are silent carriers, compared to the unaffected non-carrier, meaning they have inherited none of the abnormal alleles. Pathogenic just means that it is known to be disease-causing. This is based on a variety of factors, as well as lab variant curations, to determine how deleterious a variant is. Importantly, the term mutation used to be used, but we really refer to this now as pathogenic variants, and you'll hear me speaking about that today. In terms of more clinical testing, we know that we can do electrophysiological studies, or EMG, muscle biopsy as well, but these can be helpful but are much more invasive than the non-invasive GAA enzyme assay and or GAA gene sequencing testing. These latter two tests, the enzyme assay and the gene sequencing testing, are preferable now because they will more fully capture the diagnosis. They'll help determine the classification of Pompe disease, infantile versus late onset, alongside, of course, a detailed clinical evaluation by an expert clinician. Supportive lab findings are also helpful in making and confirming the diagnosis, and these include an elevated serum creatine kinase, or a positive newborn screen result in certain states that are doing that screening. And this newborn screen tests for acid alpha-glucosidase enzyme activity and is performed on dried blood spots along with other newborn screen testing. Another important test, GLIC4 in urine, also known as HEX4, is a biomarker that has age-dependent norms. This HEX4 is a reflection of glycogen accumulation, but it is not specific to Pompe disease. This elevated urinary oligosaccharide, HEX4, can be seen in other glycogen storage diseases as well. Importantly, This biomarker's sensitivity is actually diminished in the late onset form of Pompe disease and has much more diagnostic value in infantile onset. In fact, it can be normal in some LOPD cases. Now moving on to newborn screening and the current state of newborn screening in the US, we see here this map that shows 24 states plus DC are screening currently for Pompe disease. All of the states shaded in are screening for Pompe disease. Some are screening for additional lysosomal storage disorders that are not relevant to today's talk, but that is why the map has multiple colors. As you can see, though, not all states are screening for Pompe disease. Earlier diagnosis is very important, and it was added to the recommended uniform screening panel as early as 2015 in the United States. However, it takes time for conditions to make it from the recommended uniform screening panel onto actual panels in every state, and this typically takes a number of years. The methodology for this testing, as I mentioned before, is a dried blood spot enzyme assay, as pictured in this right-hand March of Dimes image here. Many labs are also conducting GAA gene sequencing as a second-tier confirmatory testing on the same newborn screen blood spot card with quite a fast turnaround time. This gene sequencing helps identify the pseudodeficiency cases as well as carriers who have pseudodeficiency alleles. And these scenarios can diminish GAA enzyme activity in these in vitro assays, namely the dry blood spot, yet the patient does not have disease. Therefore, the gene sequencing testing as a second-tier confirmatory testing can be very helpful. Differences between IOPD diagnostic journey and LOP diagnostic journey will continue next. There are similarities, but there are also differences between IOPD and LOPD testing. The initial reason for presentation and the symptomatology may be very different between the two, but the laboratory diagnostic workup is actually identical for IOPD and LOPD cases. Both will be diagnosed using the same methodology, GAA enzyme testing and molecular genetic sequencing that we've been discussing. The results of the GAA enzyme activity and the gene sequencing results can actually help differentiate the two from one another. This is true in most cases, but not all, and therefore the presenting symptoms are key in differentiating IOPD from LOPD. The symptomatology and the age of onset will help differentiate the two types, and that is one of the reasons why it's so important to have a clinician who is skilled and able to make the diagnosis on a symptomatic basis as well. Looking at IOPD a little more in depth, we discussed the incidence is quite rare, 1 in 100,000 to 1 in 138,000, and the onset is before 12 months old and includes cardiomyopathy. Of note, the symptoms in IOPD may present as early as in utero. The median age of presentation in the clinical setting, however, can still be delayed up to age 4 months. Newborn screening and a greater awareness of the condition has certainly helped bring that number down, but there are definitely cases where the diagnosis can be delayed up to 4 months, even in infantile onset disease. This condition has true systemic involvement in terms of the hypertrophic cardiomyopathy, failure to thrive in feeding difficulties, respiratory distress, hypotonia, and generalized muscle weakness, as well as biomarker abnormalities, some of which we've discussed today. The natural history is that without treatment by enzyme replacement therapy, which is the standard of care treatment for this condition, IOPD commonly results in death by age 2 years from progressive left ventricular outflow obstruction as well as respiratory insufficiency. Even if properly treated early on, limitations to the current treatment do remain. Another concept you might see is cross-reactive immunologic material, or CRIM status. CRIM positive basically indicates that the patient has some endogenous enzymes still being made, and that applies to most Pompe patients. CRIM negative is the most severe end of the infantile onset patients, and these patients have a high risk of neutralizing antibodies because they have no endogenous enzyme being made. This is therefore associated with worse outcome as well as a risk of adverse drug reaction to the enzyme replacement therapy. We can test protein obtained from blood PBMCs as well as fibroblasts using a Western blot analysis as pictured below, but 92% of cases are now actually able to be predicted on gene sequencing alone, and we don't necessarily need to use this Western blot analysis anymore. But as you can see below, column 2 shows a CRIM-positive patient who has some enzyme activity being made, whereas that band is absent in lanes 4, 6, and 8, who are the CRIM-negative patient representations. Moving on to late onset Pompe disease, the clinical manifestations include progressive proximal muscle weakness, and that is in 95% of patients. They can also have respiratory insufficiency due to diaphragmatic weakness, because we know the diaphragm also includes muscle that is affected by this condition, exercise intolerance, exertional dyspnea, orthopnea, sleep apnea, hyperlordosis and or scoliosis, which has to do with curvature of the spine, hepatomegaly, which is enlargement of the liver, and this is in childhood and juvenile onset, macroglossia, which means enlargement of the tongue, and this is more often seen in the infantile onset, difficulty chewing and swallowing, in part because of the muscle of the face, GI symptoms, including irritable bowel-like symptoms, chronic pain, increased respiratory infections, decreased deep tendon reflexes, a Gower sign, which is seen in multiple neuromuscular conditions, and joint contractures. Testing guiding classification is an important concept here. As a general rule, the lower the GAA enzyme activity, the earlier the age of onset of disease. We know that all infantile onset cases will have less than 1% of a normal control for their GAA enzyme activity. In contrast, most LOPD patients will have partial deficiency of GAA enzyme activity, typically between 2 and 35% residual activity. Of note, GAA enzyme turnaround time is on the order of days, typically about 4 to 5 days in a lab. The molecular testing can be done on single gene testing, specifically looking at GAA gene if you have a high suspicion for Pompe disease, targeted analysis for a known pathogenic variant if you have a family history and you know exactly which spelling change within the single gene you're looking for, or a multi-gene panel, and that might include multiple neuromuscular conditions. Sequencing testing for multi-gene panels is about 4 weeks turnaround time typically. A single gene testing for GAA alone is typically quicker, about 4 to 5 days. The type of testing you send for molecular testing will depend on how concerned you are for Pompe disease versus a variety of neuromuscular conditions. There is a differential diagnosis for late onset Pompe disease, including limb-girdle muscular dystrophy, Duchenne-Becker muscular dystrophy, polymyositis, glycogen storage disease type 5 or McArdle disease, and glycogen storage disease type 6. As you can see, there are shared signs and symptoms, but all of these conditions are due to a different genetic cause. Therefore, these multi-gene panels are sometimes helpful when you're concerned about multiple conditions in a single patient. Of note, early respiratory muscle involvement is a key feature that often distinguishes Pompe disease from these other neuromuscular disorders. Common presenting symptoms for infantile onset Pompe disease include cardiovascular, pulmonary, neurologic, and gastrointestinal, as we've discussed previously. Here you can see there are certain pertinent patient findings within these systems that will help with the diagnosis. In contrast, we have slightly different common presenting symptoms for late onset Pompe disease. While pulmonary, musculoskeletal, and gastrointestinal are all involved, we see the absence here of the cardiomyopathy that was present in the infantile onset form. Going through pertinent patient findings, we can see again there are respiratory concerns, often musculoskeletal, gastrointestinal, and sometimes there is cardiovascular findings. However, this is not a key feature of the late onset form, and this is quite infrequent. There are diagnostic algorithms for Pompe disease now without DNA sequencing as part of the newborn screen laboratory protocol. So if a state is doing the newborn screen, they're testing the blood GAA enzyme activity, but are not necessarily doing that second tier gene sequencing testing, then you would need to go through this algorithm and do a cardiac evaluation after the newborn screen. If cardiomyopathy is present, you then need to do sequencing and CRIM status determination. If they have a normal cardiac evaluation but remain having low blood GAA on confirmation, then you would await sequencing results and follow up based on symptomatology and the sequencing results of the GAA gene. If after a newborn screen there's normal blood GAA activity, that means that the patient is either not affected, potentially it was a pseudodeficiency case, or they might be a carrier. And so they may have flagged positive on the newborn screen, but again, the newborn screen is only a screen and not a diagnosis. And this confirmatory testing can clear someone of a diagnosis and determine that they are only an unaffected carrier. Expansive molecular testing, such as exome sequencing, which means we are sequencing all of the coding regions of our genes, can actually miss a diagnosis sometimes. The gold standard diagnostic test is therefore acid alpha glucosidase enzyme assay on either skin fibroblasts, muscle, or blood. Blood, of course, is the easiest and the least invasive method, and that is usually the preferable method. Identification of biallelic, meaning two different pathogenic variants in the GAA gene, is confirmatory. However, a molecular first approach, meaning that we do sequencing of the gene before the biochemical testing, can miss a diagnosis, especially if there are some what we call intronic variants that are a bit harder to pick up on gene sequencing testing. Therefore, we would consider tests specific to Pompe disease, such as the GAA enzyme assay, when an exome sequencing does not provide a diagnosis in a patient who we are very concerned might have Pompe disease. And that means a patient with proximal myopathy, progressive respiratory failure, or other subtle symptoms of Pompe disease. The nuances of the GAA enzyme assay. You have to ensure that you look at the norms for the particular lab that ran the patient's enzyme sample. Norms are not age dependent, but can vary slightly from lab to lab. Carriers of Pompe disease may be below average for GAA enzyme levels, but will not be in the same range as an affected patient with Pompe disease. Pseudodeficiency is a phenomenon I mentioned earlier in the talk, and that is a lab-specific artifact causing lowering of the GAA enzyme assay in an in vitro assay, meaning a lab assay, but it does not cause truly low enzyme activity in the patient themselves, and therefore it does not cause Pompe disease. Molecular testing can actually help clarify if a patient has a pseudodeficiency variant versus a truly pathogenic variant, and that is one of the reasons why that second tier molecular testing has been added to some of the newborn screening states. Next, we'll discuss what medical professionals should a person with a potential Pompe diagnosis see. In terms of subspecialty providers who are most likely to make the diagnosis, these would be genetics, cardiology, neuromuscular neurologists, and pulmonology. Subspecialty providers following a diagnosis will be a little bit more expansive. Genetics, cardiology, neuromuscular neurologist, but we would add GI nutrition, pulmonology, speech therapy, orthopedics, potentially a surgeon if port placement is needed for enzyme replacement therapy infusions, potentially a G-tube surgery, as some patients do have failure to thrive in feeding difficulties, and then plus minus an audiologist, as some have lower hearing. Some resources for support include the Acid Maltase Deficiency Association, or AMDA, the Pompei Alliance, the United Pompei Foundation, NORD, which is information on rare disease in general, and sometimes has financial support for patients, and numerous social media Facebook groups. Hope Travels, Cure Pompe are some that are on Facebook. I'd like to acknowledge the Duke Pompei Research and Clinical Team, as well as these providers listed above who have helped with these slides, as well as care for our patients. And I'd like to thank our patients and their families for all of their participation in our many research endeavors at Duke regarding this condition. Thank you for your attention.
Thank you so much for your presentation, Dr. Cohen. If you give me a second to just share my screen so that I can conclude the presentation. I want to thank you for your knowledge and your expertise and everything you do for the neuromuscular community, as well as presenting today. So thank you so much.
Thank you very much for having me.
We would love to hear your comments about this webinar. If you have a smartphone, open your camera and point it at the QR code on the screen, and a link to the survey will pop up. You can also visit the URL posted in the event description to complete the survey. Thank you again to our event sponsors, Amicus Therapeutics and Sanofi Genzyme. We would not be able to provide events like this if not for their generous support, so thank you very much. If you have any questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with one of the over 43 diseases under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This concludes today's MDA Engage webinar, The Diagnostic Odyssey of Pompe. Thank you very much for watching and have a great day.